which is why it's so important that any woman that wants to become pregnant, or pregnant, to start those, the prenatal vitamins, particularly, folic acid, is really needed to decrease neurotube, defects itself. Um, and folic acid, it's 400 mics a day. Prenatal vitamins are rich in everything. When in doubt about a vitamin, you don't know what to take, just buy some prenatal. They'll give you everything going on. Plus, you won't get constipated on them. So the neurotube ones, we'll develop and talk about a few of those that we see. Microcephalic children, the heads are small, and they don't grow to normal size. They stay small, and hence the brain cannot fully expand and develop. Now, in some of the microcephalics, the brain itself may not develop anyway because of other things going on. But they're obvious when you see the head, the size of the head at the time of birth looking smaller. That's why we measure also as to what's going on. So that's one of the defects that comes with that the mosquito. Forgot what the virus is. Yes. Causes stops the development of the head itself. So these children are born small heads, and the brain may or may not even, say, be there. Okay, the Arnold-Chiari malformation is rather a unique one also. Literally, when you, okay, think of the brain when you're looking at, I'm going to say, a sagittal view of it, coming down, and it has these two little dips down in the medulla, brainstem, etc. They're known as cerebellar tonsils. Everything's sitting there, and then you have the beginning of your spinal cord, the atlas and friends that are there. Well, there's a hole, and unfortunately, those two little tonsils, they're referred to in neuro, sometimes get pushed down and into a hole that is way too big. It's a developmental thing, and that's the malformation. So it's a case of their brain is actually trying to slip down into the spinal cord area. So it's problematic. So we'll talk about that. Hydrocephalus, water on the brain. Literally, there is not good drainage of the CSF out of the brain itself, or there's over formation of CSF. Intracranial arterial venous malformation. The blood vessels, your arteries and veins become connected to each other. No, that doesn't work well, and it happens within the brain. So these are children that suddenly have a stroke, or have a stroke, and they die very suddenly, or have bleeds, lots and lots of cranial. Craniostenosis, where the skull sutures do not expand. So what are you going to, so that's one, that's your structural problems. Seizures, talk about that, infections, trauma, and interruption in blood flow. So these are all things that will come under the categories in which we see the problems that occur in children. You may not always see them in adults itself. You only see them in adults if they make it through pediatrics with it. And that's why we still see some adults going to pediatric clinics, because they actually have the problem from birth, been handled by pediatric neurologists, neurosurgeons. The adult neurologists and neurosurgeons don't know how to deal with it or what's going on, something like with the cardiac defects. So, neurotube, you've got to know, on point blank, those three things, different with spina bifida. Spina bifida, occultile, myelomeningocele, and the meningocele. Definitely going to go through that, because it tends to pop up in not just my tests, etc., but on the other exams. Okay, anencephaly. Part of the brain is missing. No one can imagine. You may see the child, they may many times have their head's a little smaller than you anticipate, but actually they are missing not growing? No. It's not there to begin. Remember, you're born with all the neurons you're ever going to have. It's now getting them connected. They got neurons missing. Lots of encephalocele, the brain and the you have your meninges, the three layers of the meninges and the brain actually are sitting just about outside the head. The skull is not closed for some reason, so when they're born, the brain is kind of sitting there looking at you. We don't see a whole lot of those, but it can be at the top or it can be below. So we're looking at other things. You said, well, I don't see any of that. No, don't forget, there's other spots where the bone has come up to cover, and it actually may have an opening there. So we see the craniofacial abnormalities that will go along with that, and the shunting that's necessary. Michael Spalek talked about, and then Arnold. Okay, with the Arnold, many times the symptoms aren't seen until they're adolescents. We don't see it in kids because they're still growing and it's not too much of a problem itself. But what happens is they start complaining. They complain of having headaches, which is understandable because of foramen magnum, there's the word I wanted, that opening down and that leads into the spinal cord. So they complain about headaches, they complain that their neck hurts, and we see this as they get closer to adolescence and start having these growth spurts that are occurring itself. Sometimes they may have problems because of the spinal nerves coming off they say, well, I was going along minding my own business and then my leg didn't want to work for a while and I was getting jitter arms. So you're looking for anything that's unusual. And when they go back, they find out that's what it is for these particular kids. Sometimes they may have a little hydrocephalic where the flow of CSF is interrupted. So they're exploring all of this. And it may also show up if they also have spina bifida, one of the varieties. I worked with a woman who was well in her 40s, she was in her 50s and all. And she went to the Bloomberg Pediatric Clinic, TCH, her entire life. She would say, I have a doctor's appointment today, and she would take the TCH because she had the Arnold, syndrome. And they would check her out, and she had made it up to that. Then one day, the brain did slip. She suddenly just had a seizure, was down, and that was it. She lingered for a while, and finally her family let her go. But she made it that long with it, with careful handling and what she did in her life, etc. And she was close to 50, I think. She made it quite a, if she wasn't, she looked a part of it. But it was stunning. Okay, so structural. Okay, your hydrocephalics, they have what's known as the obstructive and communicating and non-communicating as to what's going on. And if it's obstructed, there's something there that is not allowing the fluid to flow from the ventricles on down to the spinal cord. Remember, it flows through the brain, it's created in the ventricles, flows through the brain, and then goes down into the spinal cord where it's reabsorbed, etc. Well, obstructed, it's never getting out of the head itself. So it builds up, and we start seeing these changes that take place. This can also occur in an adult or someone older than a child, teenager, a young adult, where they may have had a head injury, and because of a head injury, playing sports, whatever the case may be, or a tumor, it blocks the fluid from flowing through. Either way, they're going to have an extracranial shunt put in. Literally, they will put a tube up into the area. If it's a tumor, they're going in after it, if at all possible. But the treatment is to shunt them otherwise, to put a tube in that's going to drain the fluid out. So, well, where does it go? The tube is tunneled down. So it's in there, tunneled under the skin, and down, usually into the peritoneal area itself, for that fluid to come down. Now, imagine this is being done to a young child. What is this child doing in the meantime? They're growing. So the tube was long enough at the time, but now they're growing. So they have to come in for revisions to have more tubing put in place. What's the other problem with it is it's going in, and we assume that everything is just hunky-dory inside of us. You know, what bacteria could possibly be there? Well, sometimes it gets in there, and now it's a freeway back up to the brain. So these children are watched very carefully and come in, and they're taught, you know, to look for signs of anything that is now different, any changes taking place, any sign that would be like having an increase in intracranial pressure, which is what's happening, or having an infection toward the brain, meningitis, encephalitis, and friends. So, it's a major complication, infection or malfunction. It is not an unusual. I saw he was in his late 60s. The gentleman came in for one thing, but then started acting very odd. His family thought that overnight he had developed Alzheimer's or something. And the doctor said, no, there's something else. All of a sudden he had developed, how does it about, communicating. It was going down, but for some reason it's still building up. They put a shunt in the old guy and he danced out the door 2 weeks later. So we never really know what may be going on. Alzheimer's does not develop overnight, but his family was ready to put him in an old age home. It looks like he was fine 3 weeks ago. What the heck? Okay, your intracranial arteriovenous malformation, as stated, abnormal development of blood vessels. And since they're abnormal, that means they are prone to breaking down, which means it's going to be a bleed somewhere in there. Some bleeds are minor, but they can build up, and they can have a major bleed, a major stroke. And then the cranial stenosis itself, premature closing. Treatment for that is they go in and literally break it apart. They literally break their head apart. They don't open it up so that the head will continue to grow inside. Any questions about those? I know it's wonderfully exciting. All right, I'm going to move on to seizures then. What time is it? 9:28? Let me take you through the seizures, which is not that long because we'll spend more time with these lovely spinal cord problems. And seizures you will have again, they'll talk about that where the spinal cord, they're not, that was Dr. Callahan that's teaching?
Yes.
So she'll hit seizures again, et cetera, but spinal cord is strictly key. Okay, seizures. Having a seizure is not the same as epilepsy. Yes, seizures, epilepsy is seizures, but epilepsy is, a seizure does not make you an epileptic. Epilepsy is something that is chronic. So unprovoked, 24 hours, it has to define. So it's important to get a good history from the child's family as to what did they see, how long did it happen again, et cetera, going on before they say, oh, she has epilepsy. Febrile seizures. Child may have them every time their temperature shoots up, but that does not make them an epileptic. It just means they need better control of whatever is causing that temperature. And then there are the neonatal seizures themselves, which is always exciting. The neonatal seizures, the incident is higher, that it usually, they occur within, because they're neonates, it occurs within the first 4 weeks of life, is what we usually see. And there's usually some other underlying condition with neonatal seizures itself, not due to temperature or hydrocephalus. So we're looking at other things. One of the things with neonates is their dosing of medication is much higher than you would ever anticipate. They get massive doses of medication for it because neonates metabolize drugs very rapidly. So you say, you're looking at this 5-week-old and looking at the amount of drug getting, you say, but I got a 5-year-old that's not getting that amount. That may be very true, but the neonates require much higher dosing. So you wanna very carefully recognize that if you're taking care of these children, you say, oh, that's way too high, and they have to have, because they blow through meds, particularly those meds. Okay, we have the general seizures, it's the whole brain, and usually general seizures are the ones we talk about it being the tonic-clonic, the whole body is involved in the seizure itself. Arms, legs, everything going on. Where the partial, there's just some area in the brain that is highly irritated, and whatever part of the brain, whatever part of the body that brain spot controls is the area that's going to show the seizure activity itself going on. Now, there are, sometimes it's interesting in some of the things to see literature coming out, particularly if it's just general literature, how they skip over some things to get you believe in a drug or different things as opposed to what medical community push out. There are seizures that cannot be controlled with medicine. It just can't. And you have epilepsy status epilepticus, there it is. Status epilepticus means that that's a seizure that cannot be controlled. Throw everything at them. So we can always go in and paralyze them, but the brain is still firing. So for these children, or any adult also, it's a case of also turning off the brain, putting it to sleep. So if it can't be, that's ongoing, and on the medication can control it, in children, they may do surgery, which means they will go in and remove the offending part of the brain. In some children, it's the only thing where the seizures are so bad and they're so constant that they went in a whole lobe of the brain itself. So, well, don't they lose intellect? Don't they lose? If done young enough, the other side of the brain will pick up the load. Remember, the brain is still developing connections, lots and lots of connections. So just because they've taken out just about a hemisphere, part of a hemisphere, doesn't mean that they've lost that part of the other part of the brain, and young children will pick up the load, and it won't be that noticeable a defect in their neurologic growth as far as the brain is concerned. So that's why it says surgery. They'll go in, if it's not a tumor, but it's that brain, that part may have to go. Okay, ketonic diets. They've also noticed that some diets make a difference. They literally, when it says ketogenic, they are putting them into ketosis, which is always fun. Usually, most people do not like that diet at all. Even the person getting it really hates the diet itself. So it has to be very gently handled, and talking about dietary control, immense dietary control, but they will actually make them ketonic, and the brain will respond to that by stopping the seizure activity. So they're going to get a high intake of fats. They will get protein, carbohydrates, next to nothing going on, just to make sure that they do become ketonic. While they're doing it, the child will become mildly dehydrated. Everything that we don't want to happen to kids is going to happen. And it will control the seizures in many children, but it certainly doesn't work well all the time. It's like being time consuming, it's just not tasty either. The placement of a vagal nerve stimulator can happen for those that also, where literally it's like a small pacemaker planted that can be turned on and off, and it controls the brain. So they tunnel it up and turn it on, and it interrupts the seizure activity. So those are what it is. So those nursing management, basically, for us is just trying to prevent any injury that they may have. Along the way, so protection. So what are you gonna do to protect them is what needs to be considered. So you have a lot of stuff that's going on. Okay, common cause, gave this to you, what's there? Severe birth injury, messy birth injuries, forceps deliveries, etc. Congenital anomalies, infection, inborn errors. There are some metabolic diseases will definitely trigger seizures, and what we see is that. As they get older, if it was a birth injury, it's still there. Then after that becomes injury, infection, trauma, and there are some genetic considerations for type of seizure that may occur. Some of the chromosomal. Okay. This is just, I don't think I gave you this, just to let you know, because we also, in oncology, there are areas that arise, and the astrocytes really is something that forms between the hemispheres itself. And they look at how many astrocytes are there. Usually you'll think of astrocytoma, which is a brain tumor, etc. But they now believe that it really has a recurring action. It plays a major part in seizure activity. So they're looking at when they look at biopsies under the slide, how many are these here, and is that what's causing your seizure activity? Okay, the diagnostics going on, looking at the magnetic encephalograms going on and looking for areas that may have small or large magnetic fields in it itself. Remember, it's massive destructive electrical activity for a seizure itself. They're going to look at their blood chemistries, their H&H, the liver, bad liver, high ammonia will certainly trigger a brain problem. They look at everything. They got to rule out everything going on. Rather for them to rule that out than just go probing around in your brain. So, and is it new? Has it been there? Is it old? What is going on based on some of the studies done, and then looking at the history. How has this child act? What were they like as a baby? Give us some information on it. When we are observing a seizure, we have to pick up and look at everything, because our assessment is going to help also with pinpointing what were they doing prior to the seizure, where did it start, was it just an eye twitching that started, or was it finger tapping that was going on, what was going on, because it's going to help determine the site. Yes, they have all of these wonderful things, but imagine being a small child. If any of you had an MRI or CT or any of that, you're in a room with all the big things going on and all, and there's a little child that's terrified. It's very difficult. They usually want to put them to sleep, keep them from moving or crying out, etc., going on with all of those. So any information that they can pick up from observation and not subject these children to all these high-tech diagnostics is helpful for child and family. So looking for the site. Generalized, of course when we see arms, legs moving, yes, but focal was just one thing that they were doing. Was it an absent seizure? Teacher keeps complaining, little Timmy looks off into the distance and won't pay attention. Little Timmy's having an absent seizure. He doesn't know he's looking off and not paying attention. He doesn't understand why the teacher's standing there yelling at him when he comes out of that seizure. Little Timmy's tapping his finger. Stop it, Timmy. He's just, okay, back to the principal's office for you. He's having a seizure. You know, babies sucking all the time. He just wants to be fed. No, he's having a seizure. Get the bottle out of his mouth. So we have to look at those things, and then the several phases, what they're going through, that will clue you in on a number of things. The preferred method is classifying it and then looking at it. The prodromal phase, when you're looking at prodromal, you're looking at anything that preceded that seizure. What were they doing? What activity itself? Every time they go outside and play, in the springtime, they seem to have a seizure. Well, what's growing in your yard in the springtime, or what's being discharged in the air, what is going on? The oral phase is sensory warning. There's something that sensory-wise, heard of adults, but kids will do it. I smell lilies, I smell ice cream, I smell, and they're taught that if they tell you anything, yes, I could smell mommy baking a turkey. Mommy's not baking a turkey. You're about to have a seizure. So learning that aura, heard sounds, I saw blinking lights, etc. What was it that, not blinking lights, those trigger seizures. I saw a light glowing on the wall. What was it that sensory-wise was the key? And if it's sensory, that also speaks to a certain part of the brain where they're going to be looking for that problem. Okay, the ictal, full seizure. Whatever's going on, they're having a full seizure at that time. Post-ictal is they have finally stopped seizing and they're actually in rest and recovery. When they're in rest and recovery, you need to leave them alone, just like you shouldn't be trying to interrupt them during the ictal phase itself. So these are the two hardest ones in children to figure out what is going on. This is much, these three are much, you see, in the adults itself. Once they're old enough to tell us that they heard or saw or smelled something prior to the seizure. Okay, you'll have these general seizures that I know Dr. We'll talk about this afternoon. Grand mal, loss of consciousness, falling down. The stiff is only for a moment, and then the body has to relax. It will not stay tonic the entire time. Why? Because they also are not breathing, and the brain is saying, I need some oxygen if you don't mind. And it will shut down, in a way of speaking, that part of keeping everything tonic, and then they'll go into the full seizure itself. They are not going to swallow their tongue. They may bite their tongue. That's the only reason we put something in their mouth. Once they started, do not try to put anything in the mouth itself. So when we see them go down, you can't put something soft. And don't put anything that's going to break their teeth. Their jaws come down with tremendous, even with children, tremendous power. So if you enjoy the tips of your fingers, keep it away from their mouth. So stiffen, cyanosis, it's temporary. They are going to get air in, but everything else is looking bad, but it's not terrible. You can put an oxygen source near them, we'll try to put it around their ears, and I'll just put it near, because they're going to take in a deep breath along the way. Salivation, yeah, drooling, tongue biting, all of those. Post-ictal, they want to sleep. They're exhausted. They have used up a tremendous amount of calories, and their muscles hurt because they have gotten basically one large cramp all over the body before they went into the clonic stage. And they're not going to feel well for quite a day, and they have zero memory. And you say, well, what happened? Nothing as far as I know. No memory of having a seizure. Okay, these are the ones we see with the kids. Typical petty mob. It may stop, period, or it may enhance itself and go into a different type of seizure activity for what's going on. And this is the one that's staring for a few seconds. It may go unnoticed, but as time moves on, it may be noticed. They may be in the middle of something and just stop suddenly, even in there's talking to you, etc. Atypical, a little bit of warning, certain behavior usually seen, and they're absolutely confused, usually by the reaction they get from anyone else around them. We also have the monoclonic, the jerking, and all of you have probably had it somewhere along the line, and you might be asleep or something, your arm will just jerk, and you'll wake up and go, what? What just happened? So it's a type of seizure. It's by itself. See some individuals, they'll be walking along and all of a sudden their leg decides it wants to go for another walk by itself. So you're looking at what's going on. Atonic is just what it is. The atonic, no tone. So literally, they lose all muscle tone, which means they fall down. And these kids, in particular, since I'm sticking with this kids, when they may be running, playing, and all of a sudden atonic, and down they go, and their head goes first. So we have to be able to just pick up on those particular things occurring, and where are the problems going on, to talk with the parents and help the parents understand. So, what are you looking for? Was there something that irritated, some focal irritation? Is it just confined to one side of the brain, or is it general? So all of those occur. I'm not going to spend time testing you on various things along here. Questions I'm interested in, or information interested from you, is what are you going to do? It's not so much that we're identifying that it's myoclonic as opposed to this or that, but what are you going to do when did you recognize that they were having a seizure, and what is your action? All right? So don't spend time, you have it here, but don't spend time saying, can you tell this from that? So, other things, Todd's paralysis, yes. It's also a type of seizure. Have any of you been asleep and thought you woke up but you couldn't move anything?
Yes.
Congratulations. You had just a wee bit one going on. It doesn't mean you're epileptic and all, it's just whatever was going on in your brain, it decided that you needed to enjoy that moment of terror all by yourself. Okay? Partials are there also. Consciousness, coccypta, we see this. Remember what I told you about that lip smacking or sucking that a child may make, going on in psychomotor seizures. We do see these in infants or children that are, infants we would expect to see it in newborns, the rooting and then going in it, but as the child gets older, we don't expect them to be sucking for a bottle when we know they're now being spoon fed. Okay, distortions. You don't want to have the parents spending time on yourself trying to have the child remember something that they can't possibly remember. Or they would say, I don't remember, I don't know what you're talking about. They're telling the truth. Their memory and thought processes are altered. So this makes it very difficult for a child in school learning or trying to recall, etc. Very difficult. Status, can't break a seizure. They have to be brought in. It is considered, just like we have the cardiac emergencies and stroke emergencies, this is a neurologic emergency. We're going to have to break what's going on in the brain, as I mentioned earlier, stop all that activity. If it can't be stopped, if the brain can't be put to sleep, put to rest, there is permanent brain damage. So people with constant seizures are going to lose functional neurons along the way. So all of those things are there for you to enjoy. Actual lesion. Okay, what are you assessing? Do you see nystagmus? Remember I told you about that oscillation of the eyes. They're back and forth, up and down. So checking on that. Their hand coordination, their gait. How are they walking? Is there a gait change? What do we see that has changed over time? When they come into the clinics and all that, they had that gait was normal during this time. Moms, they may have had 1 or 2 seizures. They come in, or is it different now? Are they? So all of that documentation, looking what was before and what is seen now. How are they doing in school? What's going on? The teacher says he seems to be not paying attention a lot more. Okay, general alertness. And then there are the medications that they get. Remember, they are on medications. Are those medications without problems? Absolutely not. There are the rash that many will get. Remember, Dilantin, one of the phentoins, causes hyperplasia, and it's the most common one that is given. Usually works well, but in young children in particular, and when the mouth given, their gums will start to grow, and they will grow over the teeth. So the hyperplasia of the Great oral care is necessary. Frequent dental visits necessary when they're on Dilantin, the phentoids. Blood dyscrasia, yes. Some of the more heavy-duty stuff, Tegretol and friends, will go down in the bone marrow. So those children on it have to come in for frequent lab work. So they haven't had any seizures, but they're awful tired, looking a little pale. Oh, dear, you know. So they have to be checked a couple times a year to see if their bone marrow is still in good shape. And then the liver and the kidneys also get a little funny about that medication. So great teaching is necessary to be sure. Well, there's no problem. Why do I need to bring them in? No seizures. Yes, but they're meds. The meds are working positive on that, but they may be doing some negative stuff otherwise. Okay. Have to remember that some of these children also are on these meds. Those with mental retardation, heavy mental retardation usually have a lot of seizures. They're very seizure prone. So they are placed on these drugs. So they have a lot of other problems that develop because of the drugs itself. Okay, take your break. Oh, yeah, take your break. You're still gonna have the nursing assessment, which talked about itself, and you have that slide.